Tony Laurie. I'm chair of the Minnesota Prescription Drug Affordability Board and call to order the July 2nd meeting of the PDAB. I note that we have a quorum of all 7 members present. We also have 2 non-voting members, and I see at least one of the 2 present for today's meeting. And for members of the public, please note that public comments will be accepted at the end of our meeting, as they are at all PDAB meetings. And we also encourage you to visit PDAB's website, where you can submit written comments at any time. One additional point that we made last meeting was that if you wish your comments to be made public, please indicate that when you leave your comments, and we will then make those comments public. Absent an indication to do so, we feel like we still should protect people's privacy if they're trying to submit a comment that is not for public consumption. An agenda was published on our website with 9 items, and we will proceed with that agenda. Approving the meeting agenda is the first item. Are there any members with any additions, corrections, comments on the agenda? Okay, without objection, the agenda published before the meeting is adopted. The next item is approval of minutes of the May 12th, 2026 meeting. Those were distributed. I have been through them. I thought they were representative of our meeting. Did anyone else have any additions, corrections, comments?
Steve had just a couple of technical amendments that we'll make.
A couple of technical amendments, not worthy of.
Well, my name was misspelled. And
second,
worthy. We identified a database called Metascan, which doesn't exist, but there is a market scan.
Market scan.
Yeah.
Oh,
exist,
okay.
So
okay.
Just technical amendments.
We will correct those 2 technicals. Any other, and I think we'll just do that by instruction. Any other additions, corrections, comments to the minutes? Okay. So there being no other corrections other than the technical with instruction to the minutes, and without objection, the minutes stand approved. It's technically corrected. So then we have the designation of the annual board meeting on July 31st. A special meeting will be scheduled for that date. According to our bylaws, we have to have an annual meeting in May, June, or July. The July 31st meeting is intended to be that, at which point we will elect officers. And I understand there's a resolution to be offered on this issue.
Yes, that's by me. So the resolution has been offered to the chair, and I move the adoption of the resolution relating to our 2026 annual meeting. It's been sent to the chair.
And we were going to have James Kennedy go ahead and read the resolution.
So I think there was a printed copy here, but especially for people online, just to make sure everybody is aware, the resolution says the following. Whereas the bylaws of the organization provide in Article 5 meetings, Section 2 annual meetings, that a meeting held in May, June, or July of each year as designated by the board shall be known as the annual meeting, and in addition to any other business, shall be for the purpose of electing officers, receiving reports of officers and committees, and for transacting such other business that may properly arise. Resolved that the Prescription Drug Affordability Board will hold a special meeting on July 31, 2026 at 9:00 a.m. at the Wilder Center, 451 Lexington Avenue Parkway North, St. Paul, Minnesota. And that the board hereby designates its July 31, 2026 meeting as the annual meeting for all such purposes. In addition to annual meeting business noted above, other business may be conducted.
All right, everyone understand the motion? Is there a second?
Second.
Motion is seconded. The executive director will take the roll.
Craig Acomb.
Aye.
Aye. Matt Anderson.
Aye.
Matt Anderson, aye. Erica Barnes.
Aye.
Erica, aye. Anthony Laurie.
Aye.
Aye. Sai Nickpay.
Aye.
Aye. Stephen Schandelmeyer.
Aye.
Aye. And Matt Tobin.
Aye.
Aye. The resolution passes with 7 yeas and no nays.
Okay, we have an annual meeting. The next on the agenda is a presentation by Dr. Amy McNally, a PDAC member, and we look forward to taking your presentation and listening to your advice.
Is that working?
Yep.
Okay.
Yeah,
Sometimes
and
it's
for
hard to-
members in the room too, probably turn your microphone off.
When
You
we're
know,
done.
there's a little button on top of it, and then if you need it on, flip it to the up position, just again with our technology.
Perfect, thank you. So I first just want to start off and say thank you to the board for having me come and present. I'm glad I could come in person and talk with you today. I am, as mentioned, Amy McNally. I am a physician. I practice with Minnesota Oncology. I'm a GYN oncologist. I have been with the PDAC, as mentioned, since its inception. Minnesota Oncology and our group was very interested at the knowledge of this kind of legislation moving forward, understanding that a PDAB and a PDAC was going to be formed very early on for two main reasons. But before I go into that, my position, therefore, on the PDAC was to represent community-based oncology practice, private practice oncology. But the unique or ironic component to that is that actually means I'm just representing Minnesota Oncology. And that will come into play in a few minutes when I'm kind of tying together some of our concerns just that we wanted to bring to the board's attention to take into consideration as you guys are moving forward, making very important and difficult, challenging, complex decisions when it comes to upper payment limits. So again, appreciate that. So first and foremost, when an opportunity or awareness of the PDAB came up, I understand that the board's initiative is to set these upper payment limits. And first and foremost, understanding that the incentive to participate and have a seat at the table is for our patients. First and foremost, we want to make sure that our patients continue in the state of Minnesota to get the best oncology care possible. We want to make sure they get access to that care, but we would be lying if we, or inappropriately ignoring how cost of healthcare is impacting our patients every day. And it is important that we participate in as many efforts as possible to find ways to improve that problem for our patients, the state of Minnesota, and our communities. So we do understand that, and it's just making sure that we are part of those conversations. And so that was key driver number one. Number two is that upper payment limits can or could have significant impact to private practice oncology that is different and unique to oncology practices in the hospital-based setting, and I'll get to that as well. But that obviously was another key factor in why we wanted to be part of this and have that seat at the table. As far as concerns to outline, one is not really unique to private practice oncology. I think from just a physician standpoint, but definitely in the cancer world, we see patients tend to choose insurance plans not for the, if I get cancer, what's the one that will help me get the lowest cost cancer care? They're choosing their their insurance plans based on what's provided to them through their employer. I mean, there's just choices in some cases. And then a lot of times the other driving factor is what's the cheapest for them and their families on those day-to-day basis. And all of us in this table, around this table who have insurance of our own, are aware that the insurance costs are just going up. And so in the oncology space, we see every day that many patients' insurance plans have just a variety of different components to them, where an upper payment limit change we fear may not really result in an actual direct lowering of cost and therefore affordability for the patients directly, right? And so we have some concerns there. Aside from that, it's talking about these could be, what about our Medicaid patients in this situation? And then the whole other conversation about taking care of under or uninsured patients as well. So that's one area that we have concern of. The second piece to it is as this board makes and the state of Minnesota makes decisions about upper payment limits, which drugs, what are those limits, et cetera, moving forward, we don't have, or you in this room do not have control of the other external factors in that ecosystem, the insurance companies, the PBMs of the pharmacies, the healthcare companies, and with vertical integration and consolidation happening more and more, a lot of those times it's all of those entities combined, as we all know. How are they going to respond to these upper payment limits as they move forward? And from our standpoint, we have fears that it could cause prior authorization issues to become more challenging, not just in a time issue constraint, but the cost. And in private practice, we have less resources and therefore more cost spending to try to get through prior authorization issues. And so could those become more complicated? And in the cancer world, leading to patients not getting the care that they need or delaying that care, which is a life potentially impacting delay. The other thing is, could there be drugs that are no longer offered in certain markets, just like what happened in Colorado? And so we concern, could that happen in oncology drugs? Similarly, having a negative impact. Could insurance companies just change their plans and how they structure those, right? So all of those, the external entities that you all are aware of, how are they going to respond to those? And do those responses, particularly in more vertical integrated situations, are those going to just drive up cost to the healthcare system, to the state of Minnesota, to our patients, to their families, and other ways that drug costs reimbursement might be lower, but there's secondary ripple effect that drives the cost of care or maybe lose access to care in response. The third area I would say is really driving down into why private practice has unique struggles or potential struggles in these situations. The risk that stands is this. In Minnesota oncology, we invest to buy drugs to stock our pharmacies with the cancer drugs to provide care at a cost. If upper payment limits are significantly lower than the cost we purchased, we still have to pay to store the drugs, to prep the drugs, to administer the drugs, which could further change that delta, putting us further, not breaking even in the red and further in the red, we are going to be in a deficit. Hospital systems in oncology here in the Twin Cities have other mechanisms to weather that delta. 340B. They have the black box called facility fees that can cover that. We don't have that capability. They have tax-free status. They have payer contracting, which of course we all know in this room, we can't share our payer contracting that we have in Minnesota Oncology. We can't share it at the hospitals, whatever, but we do know, and everybody in the room knows, that the bigger you are and the more scale you have, the likely more aggressive payer contracting you have with the insurance companies. And so they have probably better reimbursement rates to begin with compared. And so all of those extra factors that the healthcare oncology systems have in Minnesota, Minnesota Oncology does not have access to buffer those losses. In that situation, that leaves Minnesota Oncology having to turn patients away, making decisions to say, we are not going to be able to give you drug A or B, which nobody wants to have to say no to a patient. And if it's the drug they need, we're not going to give them drug B, right? We are going to send them where they need to get the care that they need. Or we're going to close our doors. We're not going to survive financially. And that leads me to just kind of leave some comments about two things. One, we know this is real risk because federally, as many of you in the room know, the IRA is similarly doing, and CMS, essentially upper payment limits for drugs. We've done the analysis to look at, like, for example, Keytruda is on the list coming up in, I believe, 2029. And if you look at Keytruda, which is one of the most commonly used immunotherapy agents out there, and it is used now extensively, even in GYN oncology, Keytruda is on guidelines now for patient care. If we were unable to give Keytruda, we wouldn't be able to give Keytruda. We've done the math. The estimates of where they're setting that upper limit and the cap and the reimbursement will immediately go underwater. And so we've been talking and going to Washington and discussing kind of ways of, they're moving forward with the IRA, you're moving forward with upper payment limit. I mean, the reality is we are trying to do, that's what you're mandated to do. Are there, just at the federal level, talking to them about ways of maybe addressing that issue so that the burden isn't on the provider? So I guess I say that first and foremost because this is not us assuming a problem. We've done the math, and we take care of a large portion of Medicaid, Medicare patients in our practice in Minnesota Oncology. So the math is pretty scary to look at. The second thing is to just briefly share with you a little bit about why Minnesota Oncology matters. So Minnesota Oncology, we are 64 physicians. We are just shy of 60 advanced care practitioners. We have 12 clinical sites across the Twin Cities area. We, last year alone, had just around 1,500 new patients alone that came into our practice, let alone those that are already currently still undergoing care or have a recurrence and are back on drugs or getting treatment. So we have a large footprint in the Twin Cities, thankfully. We have multi-specialty care and integrated care. So we're medical oncologists, we are radiation oncologists, we have multiple surgical subspecialties, GYN oncology, thoracic surgery, melanoma plastic surgeon, breast surgeons, and colon and rectal surgeons. We provide palliative care services internally. We have dietitians, we have social workers, we have a chaplain on staff for our patients. We provide the full gamut to keep patients at their, as close to home as possible in the community to get their cancer care. We know that brings value. We know that we provide care at a lower cost than the hospital systems in the Twin Cities. We know that. Part of that has to do with the fact that we know that without the facility fees and the other things added on top of it, hospitals provide infusion drug therapy in the Twin Cities almost as 3 times higher than we provide in our infusion centers at those 12 sites. So just with those dynamics, we're driving down the cost of care. The other thing is we do a lot of work keeping patients out of the emergency rooms. We do a lot of work with our palliative team to provide patients so they have fewer symptoms, we're catching them earlier, all those other things that are super important, not only for the best care of our patients, but to drive down that cost of care for those patients and families. So why I want to pause and stop and say that is if upper payment limits get to the point where we have to stop seeing certain patients, and Keytruda would be, I already mentioned, or we end up closing our doors, that is going to drive all of our patients into the healthcare system, which is going to drive up cost, which is not the goal for any of us. And it also, I fear that all of our patients, the access to care, just like if any other healthcare system right now were to shut down, where would they go? And that's going to be an access issue for the patients of the state of Minnesota. So thank you for your time.
Dr. McNally, I will assure you most of your concerns, this is not the first we've heard of.
Yes,
much of
understood.
this. And we take them seriously and really appreciate you coming forward and giving us this perspective. One thing I was hoping you could say a little more, it struck me in the portion where you were talking about the potential of manufacturers actually pulling drugs off of the market. You said, as happened in Colorado?
Well, the cystic fibrosis, the cystic fibrosis drug
Okay.
that was capped in Colorado, for the PDAB in Colorado, led to some decisions or potential threats of no longer providing that drug.
Okay, potential threats, but the UPL on that drug is not effective yet.
Oh, I know, but
there's-
once it was set, some of the feedback that was given is, are we even going to provide this care in this market?
Okay.
Could that similarly happen
Okay,
in cancer drugs and similarly happen in Minnesota? So thank you for that clarification. But yes, I'm talking.
Yep, that's okay. I just wanted to know if I'm.
That's an important nuance. No,
It's a potential threat that we recognize and have to weigh.
right. We also know drug companies are already considering stopping making certain cancer drugs already because the margin's low.
Right.
Right? That's already a threat. I don't care who you work for as an oncologist, we're already seeing that. Yep. So yes, that is a potential that's a potential unknown. Yes, correct.
Great. Matt.
So Dr. McNally, thank you so much for coming in today. Know that you are very busy. You have a lot of important work that you do, and so taking the time to come down here to talk to us is a big sacrifice for you, and I want to acknowledge that. And just want to acknowledge kind of that we are...
Say, Matt, could you turn on your microphone?
Yes, I was a little worried about...
It's right at the top.
I think it's on now. So wanted to recognize, just sort of speaking as a longtime patient advocate and also as someone who runs a nonprofit community clinic and pharmacy, that I'm deeply concerned about unintended consequences and the impact of patient access and the impact to providers. And, there's nothing that we don't want to do anything that is going to negatively impact Minnesota's healthcare system and negatively impact patients. And so hear you loud and clear on these concerns, and know that I share that and that the board shares that. And there's no one here on the board who wants to make the system worse than it is right now. And it is scary as we think about what could happen or the change. And I think the ask or request of you and your colleagues is, what could we do? What are the potential positive impacts that this board could have on patients, that could for providers, for the system? I think we are looking for all possible solutions. Yeah. And so I think, there are certainly the concerns and that we need to weigh, and also what is the positive impact that this board could potentially have on Minnesota. And so, definitely want to continue to hear from you and your colleagues on, how this could, what those negative impacts could be, and particularly on, on the patients that you serve and the medications that you rely on and utilize. But also, I think there's a great space to say, what are the opportunities? Absolutely. And sort of would love to hear from you all, and knowing not today, that you probably don't have them ready to go today, but, to keep in that dialogue and to just continue to let us know, here are some proactive ways that this board could be helpful.
Absolutely. So, thank you. And let me also be clear, I and my constituents do not have any belief that the board has any ill intent. Let me be very clear about that. And so I appreciate your comments and want to be clear I'm speaking for myself, but I know I'm also speaking for Minnesota Oncology. As far as kind of what to do, some things, number one, we would love to, again, continue to have a seat at the table and participate and be present, because again, this is not about coming in and saying, don't. Let me also be clear about that. We have to do a lot. There is not one fix for the healthcare problem that we have in Minnesota, let alone the United States. it's going to require a multifaceted approach. It's going to be nuanced. We're going to learn and fail, like all the things, right? And so when I think about some of the kind of similarities, like one thing is to at minimum keep into account like what that administrative burden cost. I mean, that idea of, you know, breaking even. And again, that's breaking even still has its, you know, try to fall out that financial that's probably just at minimum something to keep in mind when deciding. Two, I think from a national level, when we're talking about the IRA and discussing, it's that focus of that cap and what happens with that differential when we're buying drugs at ASP plus 6%. What happens with that drop in reimbursement, and trying to think of ways in Minnesota to where does that burden go? It's just like we're talking nationally. Why is that burden then back on physicians to cover that cost when we're the ones providing the care, right? So that comes to mind. And again, I am not naive to assume that it's as easy as amending the IRA, and it works differently. We're in a different situation. The board is in mandating upper payment limits for Minnesota, but that comes to mind, that concept that we're talking about on a national level when it comes to CMS. And then everything else, again, is going to require, to your point, not today, but future conversations. And as you guys are deciding or making decisions or coming up with the what ifs, is happy to weigh in and give our insight into how that plays out in our ecosystem of a private practice. And again, I'm sure that I can, and that would involve, again, time and some further thought.
Speaking to a microphone. Can you hear me? Okay.
Yes.
Thank you so much for these comments. You hit on a lot of like really important complexities in the drug supply chain. And I think the whole buy and bill type, you know, model of supplying drugs is like, can be really different than pharmacy as we often think of it, as walking up to a, you know, your local retail pharmacy. As we go through the process of, and you'll hear about this today, as we go through this process of thinking about which drugs to select and whether or not, you know, to put a UPL on them, I think data would be really, really helpful. So to the extent that you can share data with us, and any stakeholder that has concerns can share some data with us, that would be extremely helpful. Our chair has said many times, you know, we don't want to make a mess. We want to, you know, do something akin to an actuarial study so that we can actually understand if we put a UPL here, what might happen. So those data would be so helpful to understand.
Absolutely. I think that kind of dovetails with what you were saying, those further conversations, because to the point where we said, like, understanding what the direction the IRA was going, we have that data. Yeah. We love data to go through that and then figure out, and you need to not just assume fear and, oh my goodnesses, and the potentials. We can actually, that one we put on paper, right? And you can very clearly kind of appreciate that. And we would be more than happy to collaborate and partner without a doubt.
That would be great.
Mm-hmm. Thank you.
That was really great. So I kind of hit on one of the points I was going to make. I hope this offers some comfort. I mean, we're not just going to jump straight to a UPL.
I had comfort before I came. The fact that, yes.
We have 12,000 NDCs that have, been placed on our radar through a number of mechanisms. We're going to start unveiling a process that we're going to use to narrow those down to a much smaller number. We're going to work hopefully with our U of M contract to figure out what that number might be that can be subject to a cost review. And in that cost review, we will be, that still has to be scoped out exactly what's going to go in there. But that's where we're going to be looking for data on the specific drugs that are subject to a cost review. Then we determine if there's affordability challenges that warrant the placement of a UPL. So several places where we will be actively trying to figure out, is a UPL the right tool for this specific drug to make this drug work within the marketplace in a manner to help patients
Drive down.
or the system. And yours were specific mostly to cancer drugs.
Of course.
And I'm certain that there's many who will come forward with, I don't know that any cancer drug makes it through our funnel. I'm not saying they won't, I'm not saying they will. We have to work on that. But I'm sure whatever drugs make it through to a cost review, we want to make everyone in the whole, in the public and in the supply chain know we're going to be looking for that information about what are the concerns, so that we can try to craft it in a manner that really helps the people and the healthcare system. Steve.
Yes, as others have said, thank you for coming and presenting the complexities of your environment. I would have a question. Do you have patients who can't afford their Keytruda today?
Yes,
And what happens to those patients?
they don't get the drugs.
Okay.
They
And so-
usually, to be honest, then stop showing up for their appointments.
So the system right now has unintended consequences also. I don't think we
Absolutely.
intended for them not to get Keytruda.
Right, and to the point, I agree, and that goes back to, aside from the nuance of private practice oncology, the cost of care, we would be lying to you if we already don't have a problem. That's what I'm saying. I agree, we already have that problem, and that goes back to how the insurance plans patients come in with. They're underinsured when it comes to cancer care, right? And it's the statistics are shocking that even when you have insurance, private insurance, over, I think it's now 60% of patients go into medical debt with the diagnosis, even though they've been paying into insurance for their entire job. So yes, we do see, because of the nuances of their deductibles or copays or things that are excluded and all of those other things. And so patients just don't show up anymore.
And so it's not the purpose of UPLs to limit providers or pharmacies or health systems, but to control the cost of the drug itself, which has caused unintended consequences. And so if we can do that with a little more precision, are you opposed to that process?
Oh, we're not opposed to, I think that's what we're talking about. We're talking about here saying, how do we, is an upper payment limit just a cap? Are there
Cap
nuance?
on what?
Exactly. Yeah, that's what I'm
On the
saying.
drug costs, maybe not the provider's payment.
Correct.
There's a
And that's why I'm
difference.
saying it's the way that we look at it, it's not just a cap. It's how do you, when you look at that difference, like the national, when we're talking about the IRA, what happens? Who's being capped? Who's responsible for that delta difference? All of that, I think, is the discussion we very much are interested in having, because it could be more nuanced, or we hope it's more nuanced, yes.
And we understand that and are trying to understand and take into account those factors in our work. So thank you.
You're welcome. No, thank you. And I should say, because the oncologist will tell me, if patients show up and they're unable to get a drug and we've tried everything and all the other resources, we will do other drugs if we need to. I mean, I just had to. We go with other plan Bs and Cs. But yeah, it's devastating when patients' care gets disrupted because of cost. Yeah.
The underinsurance for an unexpected cancer diagnosis is a well-known problem. I've often sort of described some of our problems with healthcare and the overlap of politics, that you go into a room of 100 people and you ask, okay, who wants the coverage that is just for healthy people and that is really cheap? And 95 people are going to raise their hand.
Yeah.
You tell me where politicians are going to go to design a system, right? But then the other 5 people in the room are like, but then I die.
Yep.
It's the system that we're working in, and it's incredibly complex, and we want to help. And we thank you very much for helping us understand from the perspective of cancer drugs,
Yes.
what some of the potential unintended consequences would be.
Yep. Thank you. And again, we're engaged then, now, whatever way we can help provide the board support or information or discussion. So thank you, everybody, for your time.
All right. Well, now we have Annalisa Stieber and Pam Mink from the Health Economics Program at MDH, Minnesota Department of Health, for discussion about APCD largely. Welcome. Thanks. And we got and we have a presentation, so just for the public to forestall questions, this will be made public and posted to our website. Yep. All right. Welcome.
Thank you. Good morning. There we go. Okay. I am Annalisa Stieber, and I'm joined by my colleague Pam Mink. And we're going to do an overview of the Minnesota All-Payer Claims Database and put it into context with some other MDH prescription drug resources. A little bit of this is repeat. I've presented on a lot of the first bit, but it's been a little while, so I'm just going to do a high-level overview so you can help put it into context, I think, when you hear Pam talk in more detail about the APCD. So to get started, Vernon, thank you. So we're both in the Health Economics Program. We sit in the Minnesota Department of Health. So we have a pretty varied portfolio, but it all comes down to a combination of data and research with a policy lens and doing work in that space, in short. So next slide. Also, just for a little bit of context and kind of where we sit, again, we are both part of the Health Economics Program. The two kind of purple-ish blocks are our units. I lead the Pharmaceutical Economics Policy and Research team. Pam leads the Health Services Research team, and we sit amongst a variety of other groups doing space in this kind of like systemic healthcare realm. We also sit, the dotted line goes to the newer Healthcare Affordability Center, which I believe many of you are aware of as well. Okay, so reminder here, pieces of within the Prescription Drug Affordability Statute that outlines MDH's obligations towards the board. There's three main categories. The first is to provide data from the Prescription Drug Affordability Board, Prescription Drug Price Transparency Act to the board, excuse me. Second is technical assistance, and third is consultation. And again, I'll go through these just briefly here. All right, so first, looking at the data. Next slide, Vernon.
Oh, sure.
It's all right, and then next slide again. Okay, so this is a little bit about the Prescription Drug Price Transparency Act. So there are multiple data streams within that act, and just doing a little bit of clarifying here. So actually the streams are the third row down, so kind of purpley color. We talk about price growth, new drug, and drugs of substantial public interest. And they all have kind of their unique factors within the act. The left-hand side, there's statutory thresholds for reporting. So if a manufacturer sets a price at a certain price point and it meets those criteria in statute, there's a requirement to report. On the right-hand side, it's different. That reporting is identified by a list of drugs identified by the department. And that's the drugs of substantial public interest. And then there's different reporting entities. Largely manufacturers, and so that's only manufacturers for the price growth and new drug, but then we get more supply chain actors in the drugs of substantial public interest. Next slide, Vernon. So what's in the red square is the data that MDH is required to give to the PDAB. So the drugs of substantial public interest is made available online. It's public data, it's transparency, but that what's in that square is what's specified in statute. Next slide. Moving on to the technical assistance. So this is MDH supporting the PDAB by helping identify specific drug products that meet the criteria under 62J90 subdivision 2A. So those are you guys have gone through these. And this is what drugs meet those. So this we have already provided. The current list that we have online is from December of 2025, and it includes 919 specific NDCs and kind of which drug products those meet, which criteria those drug products meet. That is there. You guys have already looked at this. But a quick note that to pull this list, we use a variety of data sources in order to pull this all together, including Metaspan, including publicly available FDA data sets, and including the Minnesota APCD. Next slide. And then third, consultation. So this is a little broader. It's a little bit less specified, but I think this is really where the legislature said MDH has data and expertise in drugs that can help the PDAB and in a variety of ways. And so I think this is kind of this slightly less specified bucket, but kind of what we're talking about for the remainder of our time here today. So next slide. So again, to kind of review, these are the data sources that my team primarily uses. So on the left-hand side, and I'm going to go into these in more detail, data on the Prescription Drug Price Transparency Act, the 340B transparency effort as well. We purchased a Metaspan license, and we use the APCD. And then on the right-hand side, a variety of publicly available data sets that are that anybody could get. Next slide. Okay, so I don't want to walk through this in excruciating detail. You guys can look at this a little bit later, but did want to kind of walk through each of these data sets that MDH has and kind of talk about how we can work with the PDAB in using those data. So the first two rows are both the Prescription Drug Price Transparency Act, and there's kind of those two parts roughly. So again, price growth and new drug data goes to the board, and so what the data that we collect from drug manufacturers includes data that are public, not public, and trade secret. The data that's made available online are the public data. We receive the not public and trade secret data, but they're not available online, but they can be included in things like summary statistics, aggregate data, so long as it's not identifiable. What goes to the PDAB will include the trade secret and not public data. For the drugs of substantial public interest, it's what's made available online is also available to the PDAB there. For the 340B covered entity report, this is a couple years old. We're in our third data collection period right now. These data are non-public, and so what are available in the legislative reports are what are available to the public and to the PDAB. For Metaspan, I know that we've talked a bit about this. So MDH purchases a license with a specific use case for MDH prescription drug work. So that can be made available in essence to the board via consultation with us and within the limits of that license agreement and that use case. That use case includes work on prescription drug affordability in the state. So like but it's not giving the data set, but it's whatever is within the use. We can use Metaspan with our work in consultation with the board. And then finally, Minnesota APCD. And this is where we're going to focus the rest of our time with Pam. But just wanted to call out summary data are available via public use files. I think you are aware of that. And then again, via consultation with the department and in accordance with Minnesota law. We can run the analysis and we have all of these data sets kind of hooked up and together in a way that we can leverage them together, which is the most helpful. And with that, I'm going to turn it over to Pam.
Great, thank you. So just sort of at a high level, what are all payer claims databases? There's statewide repositories of healthcare claims data collected from public and private payers. And this map just shows other states with APCDs and kind of where they are in the process. When I first joined MDH about 10 years ago, the map was much lighter colored, so it's a really growing thing. But Minnesota was there pretty much near the beginning of all of this and have had an APCD since 2008. Next slide. So we use the APCD for a lot of different things, and I just put them on here so you could see the extent of it all. There's a link to our publications page if you're interested in finding out more. But, you know, ranging from things from epidemiologic studies and public health studies to really focusing on healthcare spending, healthcare system functioning, things like that. Next slide. So in Minnesota then, what we have in the APCD is a collection of enrollment files, medical, pharmacy, and coming soon dental claims. And it has the information on the adjudicated prices paid, as well as providing data that we can use to assess utilization. The spending data includes the plan paid amount as well as the patient share through copays and deductibles. And it's a really rich data set. You know, it has diagnosis codes, ICD 9 and 10 codes, depending on the year, to look at that, so you can have the context for the services or drugs being provided, information on the treatment delivered, the information on the provider, including specialty, and then some limited data. It's a de-identified data set, so there's not, they're not individual identifiers in the data, but we do have information on age, gender, and then residential zip code.
Can I interrupt with one quick question?
Yeah.
So on the collects data on healthcare utilization prices and spending, it's the amount that the plan paid and the amount that the patient owes but may not have paid.
Yes.
So
yeah.
people that are going into medical debt, as our previous presenter was describing, I have a $8,000 deductible. The APCD says, here's the amount the plan paid, and the patient owes the other $8,000.
Well, here's how much the patient owes, yeah.
And whether or not the patient ever paid is...
Right.
Would not necessarily be reflected there in the claims.
Right.
But you would know, and again, right, wouldn't say if somebody's paid it or not, but you would know sort of what the burden is.
Right.
And can sort of separate that into the, you know, the $20 copay from the, oh, you still owe, you know, $8,000 on your deductible.
Right.
Yeah.
Thank you.
I have a follow-up to that question.
Sure.
And, to kind of build on that, and the data wouldn't reflect like patient assistance programs as well, it's just what's owed? We wouldn't have line
It's what the,
on-
right, it's what, yeah, so
Like
all
that.
we see is what's transacted through the claims.
Okay.
Yeah, so if something is happening outside of that, and that'll come into play, you know, when we talk about the pharmacy data and rebates and things like that as well.
Yep.
So what we have in the
And
sort of
Pam.
oh, yes,
I'm sorry. This is Craig come online.
sure.
I'm curious too about, it's funny because I can hear my voice again as I talk. I'm curious about how complete the data submission is from all payers currently.
Yep, you read my mind about what I'm about to tell you next. So from the public payers, so from Minnesota healthcare programs, which includes medical assistance, Minnesota Care, as well as some specialty, and for Medicare, both Medicare Advantage and Medicare Fee-for-Service, we say over 95%. Virtually, we should have everybody. We just leave a little wiggle room for incomplete. For the commercial plans, beginning in 2016, due to a Supreme Court decision, we can't compel ERISA-governed private insurance plans to submit data. Some do voluntarily. We're hoping more will do voluntarily. So we estimate that from 2016 forward, we probably have 40%, a little more than that, of the commercial market. So what we do have is we probably have most, if not all, of the people who have individual plans, small group plans, MNsure plans, things like that, fully insured plans, as well as self-insured plans that are not governed by ERISA, should be. So, for example, the state employee health plan submits data. So, and I'll talk a little bit more in an upcoming slide just about how up to date. This slide, says we've got things through second quarter 2025 for some things, but we'll have complete 2025 soon. Next slide. So I think most of you probably understand the whole process of the claim, but basically the claim is generated at the point of service, at the point of filling a prescription. The provider or the pharmacist then submits the claim to the insurance plan. They reimburse the provider based on their contractual information. And then if the patient hasn't already paid their share, then that would be when they would be told this is the final amount that you owe. And then we receive the claim. So we get the data submissions from the insurance plans themselves, or the TPA, if a TPA is being used, the third-party administrator, or the PBM. Next slide. So the APC, as I said, has been around since about 2008, and it came out of the Bipartisan Health Reform Initiative in 2007. Initially, it was set up in part to look at health system performance and to report data on that. That subsequently changed and was kind of removed from, or at least suspended from our statute, and really a focus more on research, evaluation, information sharing, things like that. Starting in 2016, we began developing the public use files that Annalisa mentioned earlier. And the focus of our work really now is to improve the understanding of patterns of healthcare use, spending, prices, and to bring data to the table to help address challenges in whether it's public health, whether it's healthcare markets, quality of care, and rising costs. And then I mentioned dental claims are coming soon. That comes out of 2023 legislation. We'll also be collecting data on non-claims-based payment, and also setting up a program to expand access to the APCD.
If I could, what's the expanded access to the APCD? Who's going to have additional access to what?
Yeah, so per the statute, researchers can apply for access to data sets. And we are in the process of setting up, so there will be a committee that will review those applications. There's a set of criteria, that what it can and can't be used for. There's also, the statute that says what the data can and can't be used for. So people can apply for a standard data set, a custom data set, a limited data set, or for organizations that don't really have the capacity to analyze data but could put the data to good use. We can do that on a limited basis. So that's, we're working on setting up all those processes now, and we're hoping in 2027 that can begin.
Okay.
Yeah.
One more just quick clarifying question. Non-claims-based payment, how is that defined?
So it's payments that go from the insurance plans to the providers that is outside of the claim stream. So something, if it's a pay for performance, rewards, and things like that, yeah, that would be one example. Some of the accountable care, those kinds of additional payments that don't flow through claims. It turns out even when you have, say, a value-based payment model in place, there's still transactions through claims, so this is that sort of extra. So if, our goal is to understand kind of as much as the total of healthcare spending, at least in these types of transactions, this fills out the picture by adding the non-claims data. And we did a pilot study of that a couple of years ago, and then we're going to begin collecting data very soon. So what is in the data? As I mentioned, it's a de-identified data set, so we don't have date of birth, but we do have patient age. We don't have names, we don't have social security numbers, we do have gender, we have the residential 5-digit zip code. I mentioned the diagnosis codes, the CPT and HCPCS procedure codes, NDCs for the pharmacy claims. You could use it to look at duration of treatment, so the length of an inpatient stay, the cost of service, including the patient share, some information on the billing provider, and then the payer themselves. So what's not in there, those personal identifying information. We don't know information on patient income. We don't have the kind of clinical data that would be in an electronic health record. So we know, for example, if a lipid panel was ordered and paid for, we don't know what their LDL level is or their blood pressure, things like that. And then, yeah, we know, I'm sorry, we are working on collecting better, more complete, accurate race and ethnicity data, but that's a work in progress. Next slide. So for the prescription drug information from the pharmacy claims, what we have would be the prescription fill date, the pharmacy that filled it. We get data from the mail order pharmacy providers, the prescribing provider, and then the payments that we've talked about already. And then in terms of the drugs, the NDC code would be there in the pharmacy claims, day supply, 30-day equivalents, whether it's brand versus generic. And then as Annalisa mentioned, we supplement this with our Metaspan access and license. So through the generic product identifier, you can tell a lot more about the drug, including the therapeutic class. Steve?
Pam, just to be clear, this is outpatient prescription drugs.
Right,
retail
It
pharmacy.
doesn't include inpatient hospital, the oncologist billing for drugs or drugs in other settings.
Right, the drugs that are administered in medical settings show up in the medical claims, so I'm kind of focused on the pharmacy claims here. Because of, you could still apply the Metaspan information for the drugs we know about in the medical claims, but yeah.
The only reason I ask is all drugs are in our purview, not just the outpatient retail. So we have an interest in looking at both.
Yeah,
the whole set.
and yes, and as you know, you've looked at the medical claims drugs in our data in the past.
Do you have NDC number for medical claims drugs?
No, I believe, if it's there, it's there. I think it's not
required by Medicare and Medicaid. Can you begin to ask providers to give you that? Because that's a critical piece.
Well, we get the data from Medicare or from the Medicare Advantage plan, so we could look into that more closely.
Great.
Have you looked at?
We'll look more carefully just to confirm what's there. But
yeah.
Oh, I wanted to confirm though, like, are those data available for researchers to use at the same level of access that that the pharmacy claims are available to use? What I'm trying to say is the medical drugs, we're talking about the pharmacy drugs. Could, PDAB access those medical drug claims if that was part of this?
I mean, as with the same caveats as before, yes. I mean, they're all part of the APCD.
As long as the NDC is identified in the claim, you can access it.
It's a different data ask. I mean, that's kind of the short story. Going through those medical claims and parsing through that is a little bit, it's a different challenge than the retail pharmacy ones.
But so like there are ways though to maybe infer what NDC, you get information on it's this drug and this procedure code indicates that this drug was administered, but one could in theory try to map which NDCs that corresponds to.
I think it's maybe more in the we have good estimates on what they could be, and some of those diagnostic codes and things like that, and like medical claims for oncology, large part of those costs is for the drug as opposed to other medical services where it's more services and various other things. So there's ways to get at it, but it's again a different endeavor with a different level of effort trying to parse through that, and what you can expect back is different too.
And there certainly are some medical claims where that a drug was administered and you don't know exactly which one.
Yes.
Yep.
And again, you could tell, well, it's probably a chemotherapy drug, but again, that can.
But those are sort of general problems with outpatient drug claims for hospitals.
For drugs administered, that
Like
show up on the
Medicare,
on the medical claims.
Yeah, that's right.
Next slide.
And so
sure.
One more quick question. So infusion drugs maybe administered in an infusion center, do those show up in your medical claims or your pharmacy claims?
Those show up in your medical claims. When they're administered in an office setting or an infusion center, those would show up on your medical claims.
I would think those would be interesting to our group.
Yeah, and a lot of those drugs that are administered in the clinical settings are some of the more costly drugs. So yeah, I would imagine they'd be of interest. Okay, next slide. So I think I mentioned most of kind of the characteristics and some of the strengths and limitations. So I won't repeat those. I will say that having the zip code level data on the patient does allow us to link to other data sources. So we don't know individual income level, but we can use the zip code to at least understand a little bit about the income in the community where they live. And then the limitations, right now, the public access is limited, where I mentioned that the expansion program we're working on, I mentioned the clinical data. What's not in the APCD, in addition to that gap I mentioned in the commercial, is we wouldn't have data on uninsured Minnesotans. We don't collect data from federal programs like TRICARE, healthcare that's covered by VA benefits, healthcare that's covered by Indian Health Service, and then some sort of the more specialized things that sometimes cover healthcare like auto insurance or workers' comp. And we also don't have Medigap. And so for fee-for-service Medicare, it's an important caveat to remember because sometimes the Medigap picks up some of the copay. So that's important to know as well. And then the pharmacy data claims, we don't have data on rebates or coupons.
Do you get data from county-based purchasers?
Yes.
I think we do, yeah.
Pretty sure, not 100%.
Yes, because they're contracted with the Medicaid agency, that's a aspect of your contract.
Yeah. And so here, this is just to show kind of the recency of the data. So this is for what we call Extract 31, which should be available in the next month or two. So for commercial, for Medicare Advantage, and for Minnesota healthcare programs, it will be complete data for services incurred through the end of 2025. And that's with at least 3 months run out, which, with the adjudication process and things like that. For Medicare, traditional fee-for-service Medicare Parts A and B, the medical claims are through 2024, the Part D through 2023. We do get some of those. Some of that information gets submitted by the pharmacy plans themselves, so it's not that whole chunk is missing, and we can, if that's important to know, we can kind of evaluate what we have there. And then for Medicare Advantage, it's complete, including for their prescription drug plans through 2025 in this next extract. Right now, we're just halfway through 2025 in the data we have right now.
So about a year and a half lag. Basically, looking at this, we basically are, or no, sorry,
half a year.
6 months, half a year.
Yeah, and that's something, right, that's something that we used to, I think data were submitted they had to be submitted either annually or every 6 months. Now we have monthly data submission, so that allows us to do kind of quarterly extracts, and so we're getting caught up. So even just a couple of years ago, the data were more out of date, and now we're able to be much more timely with what we get. With the exception is the fee-for-service Medicare, because we get that from CMS and they have their process and their timeline.
Have you asked them if they can speed up their timeline a bit, or?
CMS?
Yeah.
I sent them a letter, Steve, and I haven't heard back.
Well, why not?
But maybe you could. Maybe if you and I both asked, we could get it.
Come on, people.
Tick-tock.
What share of the claims do they account for?
What
share of the total claim set does Part D fee-for-service account for?
Oh, that's a good question. I don't know, I can't do math in my head. But I will say, we wouldn't have the medical for that definitely lags, but we do have some of the pharmacy data for the standalone plans when it comes in. So, these are great questions. Are there any more? Because I think this is my last slide.
This is the last one?
I think so.
I had a question.
Yeah.
Oh, someone.
No, go back. I'll go back.
Yeah, that's the last one.
Sorry. Okay, so I think I heard you say something so you can see out-of-pocket liability, right, for a claim. Did I hear you say maybe you could figure out how much of that is copay versus co-insurance? Or did I make that up?
You made that part up. Unfortunately, no, but we can separate. So the copay and co-insurance go into the same field, and that's the data submission. It would be nice to separate it. That would take a rule change, I think, or at least a change in our data submission. But we can separate that from deductible.
Okay.
Okay.
Yeah. So that's
really interesting.
Mm-hmm.
I don't know that I've heard of that before. Is Minnesota alone in being able to do that, or is that a standard APCD?
I think it's kind of standard, okay. but I don't know that for sure. But yeah, no, it is. It's because it's the deductible where you often see a lot of variation, and we have a separate kind of work in progress, just looking at out-of-pocket burden on Minnesotans in commercial plans, both for medical and for pharmacy. And so you kind of look to see over time, especially on the medical side, how the proportion of people who are spending, or at least on the hook for $2,000 a year just keeps growing.
Because several meetings ago, we had a presentation from a patient group, and we had kind of a discussion about, they were sort of looking at different points in the year, people found things to be affordable or unaffordable. And I think to a lot of us, that immediately what popped out of that is, well, there's an insurance design thing that's happening here that's sort of out of the purview of the board. But this having information on whether someone is beyond their deductible.
What they're on the hook, yeah. And it's really challenging to look at that, what happens through the year, because for people who have kind of consistent ongoing needs, then the beginning of the year is going to be rough. If you have, a complicated delivery or a car accident in September, September's going to be rough.
Yeah.
And,
Yeah.
All right. Any other questions of MDH? All right. Well, thank you for that. That moves.
Can I
Go. Yeah, Matt.
Just a really broad question for both of you. Do you have ideas or suggestions in your consultation role with the board of things that you think you could do that would be really helpful that we haven't asked for, or that you're waiting for? Like, if they would just say, sort it by left-handed people, we could, like, we don't know what to ask. What would you suggest, or what would you sort of put forward as this would be really cool?
I have to think, because I don't have as much context of what you've already talked about.
Yeah. I'm going to flip it. I'm happy to think about that. But, I mean, thinking really systemically about the prescription drug market and trying to think about unintended consequences and like where there's need, there are pockets of the market that are competitive and prices are reasonable and the system is working. There are other pockets that aren't. And so I think it's kind of using your expertise and, the access to get input and that sort of thing of like, where are the pockets where UPL is needed because the market itself isn't working, right? Yep. And there aren't other mechanisms, because there are other regulations, state, federal, all that sort of thing that are acting in some areas. Whether or not it's helpful, I think, is another question, but so where is the UPL needed in the market because the market itself or other forces aren't doing it? And that's where we're seeing whether it's patient or state, spending cost problems because of that. And I don't know how to answer that with necessarily the data we have. That's kind of more, like I said, kind of a systems thinking, like it's how does the system work and where are the levers that exist, and not like, because you can look at where there's high drug spending all you want, but that's a little bit of a different question than kind of like the market piece.
I would love to be able to have those conversations and to be able to work with you in looking at your data, to be able to weed out, because I think that is exactly where we want to be, is where's the market failing? And we need something else, maybe not even to make the market work. UPL may not actually make the market work, but it at least mitigates the dysfunction or the impact of the dysfunction. And other places where the market is working, UPLs might do more harm than good, right? So,
yeah, and I would add, places where the market isn't working and there aren't other policy levers in action currently attempting to address it, because then you lay multiple policy factors.
Which one is working, which one's
and it becomes complicated. But I also really appreciate your question, because we have an ask built into the next presentation of MDH here, so it's actually a good segue.
I think the only thing I'd add to that too is for each of these is to really consider what the impact is on the patient, because again, you could have, a negotiated drug price that maybe is uniform across different plans, but the patient's share could vary. And so understanding, those kinds of things, to, how is it impacting, certainly having an impact on, as we heard from the person from Minnesota Oncology, of like what they're able to do, but also, what's that doing to Minnesotans?
Right.
Yeah.
Steve.
Annalise, if we could ask your advice on another related issue. Certainly we will look at and use the data and work with you to use this data to address our issues. But one thing we also are authorized to do, and we may do or collaborate with you on doing, is collect data from manufacturers. Can you give us some, nothing confidential, you can't release anyway, but general advice on how long does it take to collect that data from a manufacturer? When you put together a form and send out a request, how long does it take to collect that, and what percent have responded, what percent don't? What's the success rate at collecting data that way?
Yeah. I think an advantage of our program is that it's standardized, right? We have a specific set of data that they have to submit on. We have given advance notice at various stages as the reporting requirements have expanded. Whereas I think the PDAB, it might be more unique requests each time, and so that changes maybe the response time generally. But
even with your standardized approach, how long did it take?
I would probably put manufacturers in 3 buckets. About a third of them are incredibly responsive and they submit their data. They have 60 days to respond and to submit data to the department. So like a pricing event occurs, they have 60 days to submit. About a third are right there. They're submitting, their data are reasonably good, that sort of thing. About a third ignore us entirely. And about a third maybe either push back or ask questions or are late, or we have to work with them on data quality or that sort of thing. In a really generalized way, I'd probably put them into those categories.
Do you have any enforcement tools if they don't comply?
Minnesota has statutory authority to issue penalties for non-compliance.
Have you exercised any of those?
Not to date.
Okay. About how many drugs at the molecule level and or NDC level have you collected price information on?
For price growth and new drug combined, there are about 1,000 pricing events that are required to be reported a year.
So that would be at the NDC level?
At the NDC level. Right. Many of those are repeats. right? So like, even in a single year, a single drug might increase its price multiple points that would require reporting.
Yeah.
And then there's the drugs of substantial public interest, which then again would add to that list, which has been, what, 200 to 400 drugs a list.
About 200 to 400, that's at the
Which is what we've
molecule level?
chosen. There's a statutory limit of 500 NDCs per list.
Okay. Okay.
And I'm curious, I wonder if I could go back to an old slide. Can I drive?
I need to put Annalisa's.
Yeah.
You can drive.
Because there was a slide that gave a little bit of insight into which drugs you've already collected this data on, and it might help feed our thinking on which drugs might be amenable to a cost review. I mean, honestly, if you've already done a lot of the work that we would otherwise need to duplicate in order to do a cost review, I'm connecting a few dots here, but I'm assuming that if one of the drugs that we intend to do a cost review on, you've already done your work for some of the transparency, I think that our relationship in statute would allow you to share with us the results of your data collection efforts. Does that make sense? And is that a decent?
So, I mean, it's a transparency effort. So the data we collect go online, and are available to the public, again, except for those specific data elements that are marked as not public or trade secret. I think my outstanding question would be, what kind of information are you needing for the cost review? Because, we're getting wholesale acquisition cost. We're getting some international prices on the price growth and new drug data. We are getting some input costs like marketing costs for the manufacturer. For the drugs of substantial public interest, we're getting a lot more of the transactional costs along the supply chain, inclusive of rebates, inclusive of various other fees back and forth, and things like that. And some qualitative data in general comments or some kind of like, why did your price go up descriptions. I don't know how much of that is what you're looking for and what you're doing in the cost review for a potential UPL. And there are some pieces, like for the drugs of substantial public interest, where we have done work to identify the drugs that are of interest. Mm-hmm. And that analysis is largely available when we post the list. So for the list we released this spring, the first Medicare drug price negotiation list, we kind of was like, all right, how much are Minnesotans currently spending on these drugs? We did that for 2024. If you apply to the maximum fair price to every transaction in the state, which is not the scope of that law, but hypothetically, right. What would that be? Less rebates. So that's gross price, not net price. Like we aren't able to, as Pam said, we don't have that rebate data to really get a full picture. But that sort of thing. So, I mean, I think those are pieces, but I don't think they're the full scope of what I would imagine you might do in a cost review.
Right. And we have yet to scope what the exactly cost review is going to be. That's.
And one of our challenges is, I don't think it's a matter of a discrete list of questions only that we need. We're supposed to look at the market context. And each company may have a different story and tell it in a different way with different data. So I don't think we can just say we only want these 6 data points. We need to see what they provide and the context and put it in context on a drug by drug basis. So it's not simple. I understand your question, but understand ours too. We have to look at the context of all of that as well.
All right.
Good. We appreciate the groundbreaking work you've done in collecting data and organizing it, because it's not simple. It's a massive undertaking, and I'm sure you've learned along the way and you're continuing to improve that process.
All right. Well, any other last minute questions? Okay. think we will move to the data project, item 7 on the agenda. I'll turn it over to Vernon, the Executive Director.
Sure. So there's not a lot of slides here, but there has been a lot of thought and conversation that's gone on in terms of putting the slides together. And I'll start us out. I'll kind of lead it, but also, I mean, this has been a combined effort with Dr. Chandemeyer, with Tony, with Dr. Nick Pay, and with Joel, our contractor, and Erica Barnes, who's also on the leadership team. So there has been a lot of conversation on this, but we wanted to start out with what looks like a pretty simple slide, but has a lot of thought put into it in terms of what is the cycle going to be for us to do drug cost reviews, make affordability determinations, and then based on the results of those determinations, potentially set a UPL. So this is a slide that we're going to probably put up at the beginning of each of these conversations to just keep people on track in terms of what the process is, but also where we are in the process. Next slide just kind of takes that process and lays it over what the calendar looks like for the rest of the year for the board. So back in May, we approved what I'll call a master list of drugs. Dr. Chandemeyer, in his presentation, listed probably about 10 different lists: the statutory lists for the PDAB, drugs of public interest, Medicare fair price drugs, drugs that other PDABs have looked at setting UPLs on, drugs that patients have brought to us that they're concerned about, and a couple of others. So we've created a master list, which I think Steve has estimated as containing about 10 to 12,000 NDCs on it. So we have that list in place now. The next step is to, now that we have that list, how do we use that list? How do we shape that list so that we can start using it to make decisions? And we're using the term selection criteria right now. And the next slide will go through the selection criteria that we are proposing that we let the public comment on and that the board discuss. And the idea would be to, after the meeting today, to release that for folks to look at, comment on, provide comments to us. The hope would be that we come back on July 31st, our next board meeting, have a continued conversation of that, but hopefully come to consensus on what we're called selection criteria is going to be. And then over the course of August, probably into September, we basically apply that selection criteria to the master drug list. That doesn't, I would say that doesn't narrow the list, but it populates the list with the data elements that we think are going to be necessary or important for the board to have in front of them as they consider what drugs to actually start performing drug reviews on. So a hope would be to present what I'll call a candidate drug list, which we'll talk about in a minute, because the candidate drug list may well be the entire master list, but it's now populated with data that would help us, then help the board then decide which drugs to review. Maybe it's a smaller list, but that's a conversation that we'll have in a few minutes here. The hope would be then, after presenting that list, giving the board time to review, to think, putting the right information in front of them to come back in October and probably, I'm going to suggest later on that both these meetings in September and October be towards the end of the month to give us a little more time to do things and to get data.
Good idea. Yeah.
Because there is a variable in all of this is, we want to be able to use the APC data that MDH has. So, but a variable in that is how quickly we can get that available. And there's still an open question about other data like IQVIA data and when we would have access to that. Those two data sets are going to really be that's what's going to populate the data based on the criteria in the master list that becomes the candidate list that we looked at. But then hopefully the board is able to come towards the end of October and make a decision on drugs that we will conduct cost reviews on. And there's still, I think, an open question of how many drugs that would be, and that's a discussion we'd like to have. That's probably not just a discussion today, that's probably an ongoing discussion as we move through this process. And then once we have that, we start conducting reviews. I don't think we're making a commitment or a prediction right now on how long that review process might take. I think there is a hope or an ambition that we could complete those reviews early in 2027. And if after those reviews and after determining if there's an affordability issue or not, then make a decision whether to, announce an intent to set a UPL or multiple UPLs. Just a sec. That's not good, just a sec. Oh, okay. I didn't realize I'd done that. We've come up with a suggestion, a draft of selection criteria. Again, we're calling it criteria, but in practical terms, what it means is these are data elements that we are going to include in the master list of drugs. And they may give some direction in terms of how they're ranked on the list. But this is what we really want to discuss today. This coming out of this meeting, based on how this discussion goes, is what we would like to put in front of the public to get their comments on. And really, after I'm done talking here, the PDAC has already done some work in polling its members on what their input would be in terms of selection criteria. And well, as soon as we finish up here, we'll have Joel go through some work that he's done on this on behalf of the PDAC. But I think, Mr. Chair, get feedback from the board right now, the extent to which they've had a chance to think about this and look at it. Any comments or thoughts from the board?
And maybe I'll, having been involved in a lot of these discussions too, maybe I'll try to give some additional context and explain how we landed here and what we're thinking. And in talking to other PDABs about how they wound up selecting this much smaller number of drugs that they're going to conduct a cost review on, because this is a similar process for all of the PDABs. There's a sort of inclination to maybe try to winnow down the list before we present it to the whole board. And that requires a lot of work that honestly probably should be done in public and not delegated to a smaller group. And many of the other PDABs have sort of coalesced around the idea that, well, you should actually sort of list the data elements that are factors in the drugs that you should select and allow every single board member to engage with those. And other PDABs have wound up going through other attempted processes and landing at this. So what we're hoping to accomplish is taking the entire list of 10 to 12,000 NDCs and populating these data elements. What is the total annual spend on average on this drug? What is the annual utilization of this drug? What is the cost per day of treatment to patients prescribed this drug? And bring the lived experience of every member of this board, which is why each of us was appointed to this board, bring that to the fore and have an open public discussion about how each of us views how to prioritize each of these selection criteria. What do we individually think should be the primary factors? Why do these drugs raise to the top of this list for us? And have that public discussion and go through it, and I will call out right away. I would assume, and this is healthy for a board, that we will not all be in unison on how to evaluate what the highest priority drug for us to subject to a cost review is. That's okay, that's healthy, and it should be done in public. That's the opinion and the place where we landed and some of the thought processes behind it. So that's where we're hoping to get to today is in agreement of the board that this is a good process. If it's not, we can go back and rethink it. But that's a little bit of the background. And by the way, it would also come hopefully with technical assistance. This will be, I'm envisioning a spreadsheet with 10 to 12,000 rows, and each of these selection criteria would be a column. And if members have less technical capabilities and want some help, some technical support in slicing and dicing, we will provide that technical support. Maybe some from MDH, maybe some from our contract with the U of M, but really help members try to understand the data in front of them, how to slice it and dice it. And so this is an initial conversation about what each of these data elements in each column on the spreadsheet that has 10 to 12,000 rows should look like. And that's our presentation. And we'll spend the next couple of months, the next couple of sessions discussing this and trying to encourage the public to give their feedback. If we're missing some data element that we really should have, that should eliminate a class of drugs from our consideration, or that should highlight a class of drugs for our particular consideration, help us understand what data elements should drive our decision as we go through the difficult effort of taking this large set and coming out with the number. And we'll have to work with our U of M contract on, well, what is that number of drugs that we can realistically subject to a cost review. So anyway, that's just trying to provide some additional context on how we landed at this as a proposal for the board's consideration. With that, I'll stop talking and open it up. Erica.
Tony, you read my mind. That was going to actually be my first question, because as I think about the criteria, I think my first question would be, how many drugs can we realistically send to the cost review process? And I know other state PDABs have had a pretty short list, but what would be the limiting factors for how many can be chosen? And I guess the reason I ask that is I think that would, I don't know how I can say this clearly, that would make me understand, would we want to use a ranking system, or would we want to use like a objective cutoff? Do you know what I'm saying? Like, okay, well, we can only do the top 10 drugs that are, acting in a certain way, or can we say, like, if your wholesale acquisition cost is this much above, it triggers a cost review. Does that make sense? Clear? Well, whoever.
But I mean, okay, this is one of the things that we need to discuss also is exactly the elements that you're looking for in the cost review, and that's going to drive some of that as well. So these two things are happening in tandem, and that's one element that I don't fully understand yet in that conversation. So I can't give you great advice yet.
Right.
So
and
for folks online, that's Dr. Joel Farley.
Thank you.
Yep, Dr. Joel Farley. And yes, we needed to have you say that here, though, because we recognized we have to help you understand what we're looking for before you can answer that, what is the end? So, and that was identified by MDH too. Well, how are you going to do these cost reviews? And we're like, well,
We don't know yet.
we have our contract signed with the U of M. We're able to engage them now. We can report, and we'll be working on that and hopefully get to that end. But whatever that end is, we still need to be on a parallel track working with getting these selection criteria or data elements popular that people that members and the public recommend to us as factors that should help us narrow that list. Matt.
So I want to first say I agree with all these factors. I think this is a really good list. I think it's helpful to have something to work from and react to. So thank you for putting this together. Under other considerations, I would suggest adding, actions or drugs selected by Medicare, since that is a specific group of drugs identified by the statute that we have some direction from the legislature. I think that would be, and then drugs selected by other state PDABs.
One piece of information, the spreadsheet that we will have with the 12,000, embedded in it is why it's one of these 12,000. So it was in another state's PDAB, it was on an MFP list, it was a drug of substantial public interest, there will be a data element that says it was on this list, and this list, and this list, and this, and not this list. So that is embedded.
Can we go back really quickly to the slide with the arrow?
Sorry, that one's off.
Oh. Silence me. So here's why I think it's really important to look at this thing every time, right? The master list, we've looked at that, and that's that list of, 10,000 NDCs. That list, thanks to the data set that Steve put together, has columns in there for this showed up for drugs of substantial public interest. This drug showed up for 62J point whatever. This showed up as an MFP drug. This showed up as another. So we'll have that information in the sheet. This is sort of additional information, right? We'll also have a column for, was this a drug that someone came to the board, a Minnesotan came to the board and said, this is something that I find unaffordable. Just as a clarification.
Yeah, that was one on the patient identifier.
Yeah.
Steve.
A couple of things. One, Matt Anderson, earlier you raised a point that I think we could add to the criteria, and that is where are markets where the pricing is failing and where drug markets aren't serving us well in terms of affordability. So now I know it's difficult to measure, but that is a criteria you raised, and I think it could be one criteria that, as you said, that would point us to which drugs we might want to focus on where UPLs might actually help. So that's one criteria. I would point out that the master list itself, as people have been describing, already has embedded in it. We picked lists that have already been formed by other people. There's no drug on here that Steve put on there. Right. They're all there because they're on a list that somebody else has formed. And we've used every list that MDH has evaluated and published. And all of those are included. And one could argue that even their reports, where you looked at the percent price growth, or you looked at the absolute cost per year of therapy, those are already essentially a type of cost review based on those drugs, based on the APCD data, so, and Metaspan and other sources. So some levels of cost review. Back to the previous slide, one with the arrows again. We really need to discuss, these criteria are important, and we need to get public input and people say, A, are there other criteria, and B, how would you weight those criteria? But back to this list, they're really, we can narrow the list down, but at some point we have to do a cost review, an affordability assessment, and set a UPL limit. And we need to talk in more detail as a board about what those mean, because cost review can mean very different things. On the one hand, as I said, what MDH has done already on some of their lists, you could argue is a cost review in a sense. But a cost review could also be the process that Medicare went through to negotiate their drug prices. And those are very different in terms of level of effort. Or it could be, there are other organizations that do cost reviews, and they're very detailed, and they're one drug at a time. And they take months to do, or if not a year to do, and 10 or 12 people or more to do them. And we have, how many, Vernon, do we have on our staff?
Let's see, one.
Okay. So we need to put all that in perspective. So we'll need to clarify, what do we mean by a cost review? What do we mean by an affordability assessment? And then what are we going to need to look at to set an upper payment limit? And that may differ by different drugs in different circumstances, but each of those steps we need to understand before we can answer your question, Erica, of how many can we do in a certain time. So what level of intensity and types of information do we need? If it's just a matter of doing the cost reviews like MDH has done and have been very helpful, we can do, larger numbers of those. But if it's intensely studying a drug and looking at trying to get the data and look at their marketing costs and their R&D costs and their, patient assistance programs and rebates and looking at all the factors in the price in the market on a drug-by-drug basis, those take months to do for a single drug and months of staff time for a person for a single drug. So we need to talk about what level of review is needed at those last three steps to help frame how many can we do.
I'm just listening.
Craig? Yeah, go.
Yeah, could we go to that next slide?
Sure, just a second.
We keep jumping around.
Yep.
Actually, one more slide.
One more slide?
So I agree with everything that's been said here today. I really appreciate this list and that we're building off the work of other PDABs and Medicare. And hopefully we're going to start from a better place and not have to relearn or redo mistakes. I have two sort of philosophical questions to ask about this list. And so one is about the cost per course of treatment. And I think about a treatment that we might give that is finite, like for hepatitis, where we can give you this $100,000 treatment and you're cured. Versus a treatment where you might be on insulin for the rest of your life. And distinguishing between those two aspects of a course of treatment, I think, are going to be important. Second, I would think about annual utilization. And I'm thinking about Tony's earlier point that 95% of the population is relatively healthy and that 5% is really, really sick. Another way that I have often referred to that statistic is that if you look at the total cost of care, the sickest 5% are 50% of the total cost of care.
Mm-hmm.
And we can't ignore them.
Right.
So if I think about looking at this list and spend and utilization, all those things, I could see where a GLP-1 drugs would land probably on a review of drug costs. But I don't want to forget the 11 people in the state of Minnesota that have a rare form of epilepsy that can only be treated with a $600,000 drug. And for them, it's the difference between living or dying.
Yep.
And so I just want to make sure that we think about the needs of the many and the needs of the few as we consider how to go forward.
I appreciate your comments. And actually, jumping ahead to a later agenda item again, I looked at the PDAC's work on how we should think about selecting drugs for review, and one of the things that came out of there was actually, and it's not listed as a criteria yet, and I think it probably should be, is this for a chronic condition? Is this a curative drug or a drug for a chronic condition that will be needed? And that was identified as one of the higher things from those that responded to the PDAC as a factor. Now, exactly, I didn't have a great deal of time to spend on it, so I'm not sure exactly how they want us to evaluate that, but that would be a data element I think would be, that we're recommended would be valuable to put in our list of criteria. This one is for a chronic condition that people need to take to improve their life over the course, and it's not just a one and done, like Hep C. Erica?
I have the mic.
Oh, yep.
Kind of building on what Craig said and then what you followed up.
And Erica, could you turn your microphone on?
Sorry.
Oh.
Is it on? Hello? Can you hear me?
You want to pass it down? Oh, they got another one. I will say that the technology does seem to be working much better, and we will get used to it. So thank you to John and Wilder for helping us through this.
Can you hear me now?
Hello? Okay.
There it is.
Thank you. Sorry, I get back in my train of thought. So kind of building on what Craig said, as someone who represents a patient population, with very serious diseases in the rare space, often with life-saving treatments and limited options, I like the idea of, understanding those nuances. And I wonder if in some of our data elements, we want to take into consideration some of the FDA approvals that might help us get at that, such as like breakthrough designation, as something to just kind of factor into our consideration. So just wanted to throw, no? I don't know.
Joel, you don't have much of a poker face.
I know.
Go ahead.
Well, there's some potential criticism around some of the breakthrough designations and things that the FDA
Sure.
gives sometimes. Are they truly breakthrough or not, right?
Okay.
And so I don't know.
Yes.
There's accelerated approvals. There's all
Absolutely.
priority approvals. So
Yeah,
there are
I'm
all
not
kinds
saying
of
they're
different
a-
things that you could track in the sheet around kind of FDA approval status as well.
Yeah.
But we could track them.
Absolutely.
I mean, honestly, and whether any member uses them to lift something to the top of the list or to push it to the bottom of the list would be up to that member's lived experience,
Yeah, and well understood, Joel. Definitely, I have a pretty extensive and nuanced opinion on the accelerated approval process, as some of you may know. But I do think it's something to consider.
Yeah. Saye?
Oh, I just wanted to say, like, Craig, I totally appreciate your comment about that that drug that affects a small number of people and it has a huge impact on their life. And I think that was really part of as we talked through over and over and over again, should these selection criteria be a limiting factor? How many drugs would be limited to? How would we use the rankings, et cetera, et cetera? It became really clear that by making that decision, not potential, by not giving everyone all the information, you would basically preclude people from finding a drug that is very important to the constituency that they represent and the reason they were put on this board. So I'm hoping that by having this information for all the NDCs, it will just give a lot of flexibility for people to select the drugs that are there, that based on, we're not going to use an explicit weighting criteria, we're going to let people decide based on, as Tony said, their lived experiences. And we might want to consider asking people to write up, their rationale about why they chose the 1, 2, or 3 drugs. I don't know what the N of those chosen drugs will be, but I think hopefully, Craig, that will avoid the possibility that we don't look at a drug at all that, someone has brought to us, but it affects a really small constituency.
Yeah, because that goes right to the thing I was describing, how like if there's a pre-selection process that's done by a subgroup, we could easily miss something. I mean, it was presented, and I think other PDABs started with something like this. The top 20 drugs, or top 5, some even suggested, on each of these. And I'm like, well, I mean, the 6th annual spend with a tiny utilization, I mean, there's drugs that might be the very best drug for us to consider that wouldn't hit the list at all. And our worthy of each of our minds with technical support for anybody who isn't able to, slice and dice and figure out how to determine in their lived experience which of these would be most amenable to a UPL and bring that forward. This feels like the best way to engage every member of the board and their experience and their expertise and generate what was probably going to be a lively conversation, but come out at the end of the day with a list of drugs to forward for cost review.
Since you've given me a little latitude in speaking, and I never know where, in terms of the data project, since I'm helping with that, I hope that, you'll allow me. There are two things that I'm not necessarily seeing on the list that I wonder if you've considered. One of them is, generic status, for example. You talked a little bit about where market efficiencies may already be occurring, and sometimes that's already happening in the generic space. So generic versus brand hasn't been distinguished in any way in this list. And then the other thing that, since you're considering the lists that end up here and how the drugs end up on it, Medicare and their, fair pricing has included a number of years on the market already for a drug before they subject it to that. So when I think about some of these really high cost drugs, for example, would you want to do that in the first year that a drug is on the market? Would you want to wait some time? Some of the feedback you heard from the PDAC and some of the members, was that there was concern around innovation. So just thinking that you continue to be able to sustain that innovation prior to subjecting drugs to some of these upper payment limits. So those are two criteria I haven't necessarily seen discussed much yet, but in terms of the criteria here. So
those are really good, and actually drug product characteristics is kind of a catch-all. We actually did have the approval date on the template that we're working on so that you could see how long it had been on the market. And I know there's something about the generics. Some of the
Generic status is on there and 40 other criteria.
right.
Every criteria we can find data on, we can use. There's a balance though between how much information do we collect and how long does it take to get it versus how does it weigh into our decisions. And information, there is some information that we can get from MDH, they've already provided. There's some we can get from Metascan, which is just a listing of products by their product code, but it doesn't have any utilization. And then we go to other databases, we can go back to MDH or go to IQVIA for utilization and actual transaction costs. But the further we go in getting data, it also takes longer to prepare that and to get us to a point where we can be ready to select drugs. We could spend 2 or 3 years developing a perfect selection process to pick 1 or 2 drugs. But in the same time, we have patients going 2 or 3 years with drugs they can't afford and not being able to get access to them. So we have to balance precision and expediency here, I think, a little bit.
Mr. Chair, if I could. I think an important way to look at this, and we did have this conversation, this is the first time we're going through this process. And maybe I'll use the term, don't let the perfect be the enemy of the good, meaning we do need to get started, to Steve's point. That doesn't mean that these other issues that are brought up, if we're not able to include it in the first round of reviews, we wouldn't include in the second round of reviews. And in fact, I would suggest we do a continuous quality improvement review every time we do a review. What do we add to it next time to make it better? Because we're going to learn through that experience. So the other point, and maybe it'll come up in terms of the resolution, but it might be helpful. I didn't do it for this board meeting, but I think it would be helpful, even though it is not populated, to share the worksheet that Steve has put together. Because I think some of the questions that have come up today will be answered, because I think Steve has incorporated those elements in it. So maybe right after this, I can expose to the public as well as to the board what that, it's not fully populated, but it's a sample of what that worksheet would look like.
Right. But still as a work in progress, willing to add additional columns of data elements that are identified either through members of the public or of the, or board members. And this is, I indicated, this would be the ask of MDH too, when we're done with this, like, take a look at what we're coming up with and help us understand how long it might take, what the scope of work it would be for you to populate these data elements for these NDCs with access to your data, Metaspan and APCD, and then the various data sources that you have. That would be our ask, because yours, you know, we'll also be working with Joel's group at the U of M. We've already approved the purchase of Metaspan. We're evaluating IQVIA. You know, these can go on parallel tracks as long as one of them arrives at the station. We can use it to start winnowing down the list. If both of them arrive, great, we have even better data. But that's the conversation that's going to be going on over the next couple of months, if this proposal survives.
Can I just voice my full-throated support of releasing that spreadsheet, just because I think in interest of, like, to the public seeing all of the elements we are taking into account, because this feels really high level, and I would fully concur with Joel. I know for me, I am going to think of a small molecule drug approved greater than 5 years ago very differently than a biologic that has breakthrough designation that was approved 2 years ago, right? The innovation and R&D costs are going to look different. And so I think, like, no, and I know that nuance is being captured in the work that we're proposing. So I think it would be good for the public to know that we are considering those things, because those are really crucial elements. So, and I know for my patient population, you know, a drug at one price point for biologics is going to look really different in terms of in my thinking, the fairness of the price, you know, as compared to a 50-year-old small molecule.
And one thing that's a really important thing to say here too, to forestall, you know, a bunch of concern from different players in the marketplace. We will release everything that we can that is public, that is public, that is not trade secret, you know, proprietary, not public. It's not clear if every single data element that will be provided to the board will be able to be released to the public, but the full list of 10,000 NDCs is public. We can do that. We can indicate what data elements we're considering right now in order to facilitate productive public feedback of data elements that we might be missing or not thinking about correctly, not capturing correctly, in order to come up with what this should be over the next couple of months. And we will, according to our charge and statute, make everything that is public as expediently as possible, but we will protect not public proprietary trade secret.
I think the board discussion has been good and identified a number of other factors that we can include. And it points out that this top list are things that we plan to include, but we also have other considerations. And there were a longer list before, and we trimmed it back. But we want input from the public on the top ones, but also what other considerations should we take into account? And as I said, we've already contemplated maybe 30 or 40 additional other considerations that we could look at. We don't have to. It's up to the board to decide which ones they want to look at. But we want the public and the board and other stakeholders to tell us what other considerations should we include. I wouldn't view this list as the top 6 are important and the others might get looked at. I think they're all important. They all need to be weighed in by board members in making a decision of which drugs do we choose to focus on.
I think the top really is those identified in statute. I mean, largely. I mean,
They are largely in statute, yes.
And that was sort of the distinction. And yes, we did have more specificity in the other considerations. And the reason we eliminated that was to not make it look like this was a comprehensive list. It's not. We'll publish the spreadsheet and the list of columns that we've already identified as ones that we'll track, and taking input today, and we've gotten some good input today, and those will be added, and we'll.
Yeah, I would encourage the public and stakeholders and the board ourselves to continue to read the statutes too, because
Yes.
the statutes actually call out brand versus generic.
Right.
We don't have to bring that up. It's already in the statutes, and they separate criteria for brand versus generic in terms of price growth and absolute cost. So the statute has more in it than we realize also.
Yep.
And the statute also calls out some other drug characteristics. It says to look at drugs used in emergency situations. It calls those out specifically, and we haven't listed that here, but that may be another criteria we need to add. So drugs in emergency situations should be considered.
Say.
Does it? Yeah, okay. So in terms of an ask, are we asking board members to bring a list and the public to submit like specific criteria, potentially through email to Vernon, so that when we come back, we will, at the next meeting, we will run through that list and vote on it?
Yes, all subject to Steve's point about expediency. You know, I mean, some we will evaluate and say, wow, that would be a really nice criteria to have available to members as they debate and deliberate as to which ones make the best sense. But that's going to take us a year to compile, you know, so I don't want to make a promise that every single data element that appears in a row will be calculated and populated with precision. But yes, I think that the best public input that we should get, you know, would be what data elements are we missing? As we undertake our evaluation, what data elements are not included in this spreadsheet that you think should be important to members as they consider how to narrow the list? Yep, and members should be thinking about that and come prepared in the next couple of meetings to help us add to the list of columns that would be desirable, and the public should as well. So, Steve, I know you were contemplating just sort of to memorialize this conversation, a bit of or did you want to finish that last slide too, or?
Yeah, let's do that real quick. I apologize.
And so then I jumped ahead again.
That's okay.
But just to give Steve is probably going to offer motion for us to act on that would sort of say, this is the process we're anticipating going to gauge members' agreement in this process, and let the public know, okay, now we've settled on this as our process for narrowing the master list down to a manageable number, whatever that N turns out to be, of drugs that will be subject to a cost review.
So real quick, this is just putting in a different format what the next steps are for the remainder of this year. Again, today, thanks. We just had the discussion of the draft selection criteria, and so I articulated what the ask is for board members and the public, which is, are there elements in the criteria that we have not included to date that we should? I'll put it also in the context of other considerations that should be taken into account. To Tony's point, we'll look at all the comments, the board will, but we'll also have to weigh the value of them versus the length of time it would take to include them. Because again, to Steve's point, there is some urgency in providing relief and getting some reviews going and done. So at the end of this month, we'll review those comments, hopefully approve that selection criteria and the other considerations. We'll take the month of August, and we'll talk a little later about dates for September, October board meetings, but probably move our meetings later in the month so that we provide more time to populate the list and then run that selection criteria and other considerations against that master list. The hope would be end of September, we bring, again, what I'm calling a draft candidate list, but it may well be the full master list populated with data. And then in October, hopefully come back with that, I won't say narrowed down list, but a fully populated list of drugs, and then have the board actually select drugs for review. Obviously, there's still the open question of how many drugs do we think we can perform reviews on in this initial round. And then in November, December, and moving into early 2027, doing those cost reviews.
And we'll need to talk about the process. So we can take the what we call the master list of 10 or 12,000, all the drugs that were on other lists of other people, and we can populate it with all the criteria data that we collected. We take time and buy the data and populate it. But then we need to talk about how are we going to get from that big list to the ones we focus on. And I don't think we're going to vote one-on-one across 12,000 line items.
No.
So we need to talk about a process to work that down. Do we have each board member nominate 2, 5, 10, 50, 100? We need to talk about a process of how to do that, because it's not simple, and no individual is going to do that. An individual can say, take some criteria and say, given these criteria, here's what it would look like. But we need to collectively as a board talk about how do we get from 10,000 to 10 or 5 or whatever the number is.
Right, and so I think even
It
though.
doesn't just happen.
Well, no, right. So what probably needs to be layered on top of this is, while at the July 31st board meeting, we are approving selection criteria, but we also begin talking about what the review process is going to look like. In September, while we're presenting a list in front of the board, we're also talking about the point you just made, Steve, is how do we narrow that down to how does the board actually select drugs for review? And for example, I've talked to the other PDABs, and they've used different methodologies for this. The Maryland PDAB presented 2,000 NDCs to its board members with full information, and then each board member made their own decision on what they used top 5. What were the top 5 drugs for them based on their own personal lived experience? And then the results of those 9 ballots were combined and consolidated into what became the list of the 5 drugs that Maryland decided to move forward and review. That's an example of a process we can use, but these other elements will be ongoing conversations as we move closer to the decision point for them.
And I will call out a review of the statute again, does give voice to some of this. I mean, so we're looking for consensus on the N, and would it be 62J 90 sub 3 paragraph C says, if there is no consensus among the members of the board on whether to initiate a cost review of a prescription drug product, any member of the board may request a vote to determine whether to review the cost of the prescription drug product. So each of us, and I just think it's important to know that if a drug that we find is particularly important does not wind up on the consensus list, each of us is empowered by statute to say, you know, I think that the other 6 of you are all wet, and we're going to have a vote as to whether this one should have a cost review. You know, it's right there.
Yeah.
So, yeah, I mean, I think maybe we memorialize this conversation with a proposed resolution, and we can wordsmith it a little bit after the conversation. We wanted to give the opportunity for that, so Vernon actually typed it up and can put it on the screen for everybody to see. Steve was going to offer it.
There we go.
And I appreciate Vernon making it large enough I can actually read it, because my sight's fading a bit. what we move is that the master drug list, that is just a compilation, the list of lists, for that to be populated with the data elements representing the selection criteria that we will decide upon at the end of the month, and that be forwarded to all board members once we have it compiled, along with technical support for their independent advice about selecting drugs for cost reviews, and publishing that list and information to the public. So we're saying, let's take the list of lists and all of the NDCs and molecules that are on there, and we'll put it in a spreadsheet, and however long it is, 10,000 plus or minus, and we'll put in whatever data we decide are the criteria at the end of the month that we need to have populated at a minimum, and others that we can acquire in a reasonable time frame, we will acquire and populate. So we'll have this list of 10,000 items and 100 variables and publish that for the public and for the board. And then at some point after that, then we'll come back. So that's the motion, is to make the list of lists and to we'll, after we decide at the end of the month what the criteria are that are the minimum criteria, we'll put on that list, we'll populate it, and we'll add whether the criteria we decide as a board we can acquire and afford to get and have time to wait on. We'll put that together, and then we'll decide on a process of how do we go from the 10,000 down to a reasonable number. I do think it's also instructive to look at other bodies that have attempted to do cost reviews and see how many have they taken on. Most of the PDABs have taken on 1 to 3, 1 to 5 drugs. Medicare, that had the full resources of CMS and the federal government, took on only 10 the first year. So I think we can advocate anything we want, but I think we know the range is probably 1 to 10, realistically. And so we need to think about and talk through how now that may differ if we select 5 drugs that have already been reviewed by CMS and they already have a maximum fair price set by CMS, and our statute tells us that if there's a maximum fair price, we know what the upper payment limit is. That reduces our workload. We could do more of those, but we need to decide, is that what we want to do? Or do we want to spend our time doing a drug that nobody's ever looked at? Which would take more time to do 1 or 2 drugs, but that's fine. We can set that priority if we choose to do so. But we need to have that discussion and make that decision.
So Steve moves.
We take the master list, we populate it with criteria once we've decided on those at the end of the month at a minimum, and then we could add other things optionally that become available.
Second comment. Syed.
That sounds reasonable.
Okay.
Yeah. Do we need like an exact reading of this language for the motion?
You want me to read it?
Here it is.
Yeah,
if we're going to read
back,
it, with the exception of trade secret or non-public information at the very end.
Yeah. Okay. Dr. Schandelmeyer moves that the master drug list should be populated with the data elements representing the selection criteria, that list be forwarded to all board members along with technical support for their independent advice about selecting drugs for cost reviews, and that list be public, and publishing that list and information to the public with the exception of trade secret or non-public information. That's the motion on the table.
Any further discussion? Seeing none, the executive director will take the roll.
Craig Acomb?
Aye.
Aye. Matt Anderson? Aye. Erica Barnes? Aye. Tony Laurie?
Aye.
Aye. Saya Nickpay? Aye. Stephen Schandelmeyer?
No objection. Aye.
It's your motion.
Just testing. Just testing.
Matt Toburn? Aye. Aye. We have 7 ayes, no nays. The motion passes.
Excellent. Okay. Is there other things to cover in the data project?
I don't believe so.
Any other comments by members or? Okay. We will move to item number 8, the executive director's
Did you
report.
want to give Joel a chance to present?
Joel, oh, that was at the data project too. Yes. I thought it was in the executive director. So yeah, Joel, you did another survey to help us with drug selection criteria and data sources through the PDAC. Thank you for that. And
So I appreciate that one of the things that you're doing as part of this is collecting public input, and at least until August 1st,
Yep.
you still have a built-in mechanism for some of that public input with the Prescription Drug Affordability Advisory Council. So taking your May meeting into account and some of the lists that you were planning on using, as well as the selection criteria, we decided to collect, at least from the stakeholders on the PDAC, some of their, just some of their viewpoints on these different things. So if you go to the next slide, what we did as part of this was a survey centered around both the drug lists that were proposed at that May meeting, as well as the drug selection criteria, and asked all of the PDAC representatives, to answer this survey. There were 2 essential questions around the drug lists. They were populated with what we saw at that May meeting. The first one was just a Likert scale ranging from viewpoints of strongly disagree with the lists or the criteria to strongly agree. So it was a 5-point scale. And then we also asked members to select what, from their viewpoint, were the 3 most important either lists or criteria that they felt the board should consider in their decision making. And there were a couple of just kind of open-ended questions to allow members to also provide input in terms of some of the rationale for their decision making and other things the board might want to consider. So we developed this survey, or I developed the survey, and then used a small advisory task force from the PDAC to kind of vet this. And then we fielded this on June 15th with the idea of trying to have this information available for your meeting today. Closed that out on June 26th and sent reminders to the members. Just to give you a little bit of a viewpoint, there are 16 members here, 2 patient representatives, healthcare providers, et cetera. We did not get responses from everyone as part of this. So what you're seeing is the 6 members that responded, there in bold. So 2 patient representatives, our small employer rep, the government employee benefit plan rep, pharmaceutical manufacturer rep, and the pharmacologist representative on the PDAC. So just keep that in mind as you're reviewing this, that you don't have all of the perspectives, and it sounds like you're going to continue to get perspectives as part of this. So these are the criteria that we asked members to rate and their level of agreement with this. And what you see is the number of respondents at each of the different levels with those pinkish bars representing strongly agree with the criteria, or the list in this case being used. All the way down to blue, strongly disagree, which no one did as part of these. But and then the easiest thing that might be to look at is just kind of the mean or average score. So if you see a 5 on that, that would mean that everyone strongly agreed with this. So higher scores representing more agreement. So it seems like as part of this, the strongest agreement for criteria being used is the 62J.90 criteria. In terms of average scoring, followed by drugs that would specifically challenge state resources, and then Medicare maximum fair price lists and Minnesota patient identified things. So, give you a little bit of a sense for that. I think it's also interesting if you go to the next slide in terms of where some consensus stood in terms of the 3 most the top 3 lists that the PDAB might want to consider. So this gives a little bit of a different list. Minnesota patient identified drugs, again, rose as important as part of this. And then this time, the Medicare maximum fair price drug list rose as kind of a common consensus area, followed by drugs that challenged patient resources and drugs that met the 62J.90 criteria. Some of the comments that were provided really did highlight some desire, at least among some of the stakeholders, to really focus on those 62J.90 criteria, though. So just keep that in mind. And I provide in the report that I gave and will be posted the verbatim comments from the members as part of that. So those are the lists. If you go to the next slide, the same thing can be done here for the criteria that were being considered. And you'll see this is, at the time of the May meeting, there were more criteria, and we included all of those criteria from that May meeting. So your list now is a little bit, whittled down, but you've got these broad categories that might include some of these. So it seems like in terms of average scoring here, and there was more levels of disagreement on this as well around some of these criteria, with some folks strongly disagreeing with the inclusion of some of them. So, but the two criteria that really stood out as kind of the highest criteria were drugs with the highest annual expenditure, followed by chronic medications on this list, with drugs important to patients with real-world perspective being kind of the next level there. So you can interpret that as you will. The next slide, again, does the top three criteria, if you go to that people felt should be included. And in this case now, highest annual expenditure came out as the most important element, followed by highest average daily cost or price, highest patient out-of-pocket cost, and again, drugs to treat chronic conditions. So there was one other criteria, if I remember right, that also popped up as being important here, and you'll see the comment on the bottom from one member: drugs with highest utilization by low-income patients, patients of color, patients living in rural areas or on tribal reservations. So my summary on the next slide of this from my own interpretation of this, looking at these two different criteria together, it seems as though from the drug lists, the areas, at least among the six members that responded, where there was broadest consensus, seemed to fall under the 62J.90 criteria, and drugs that land on the Medicare Fair Price drug list, with some consensus around other things being, drugs that challenge patient resources. There was less consensus from at least this around the Trump RX, ICER lists, drugs identified by non-patient stakeholders or other state PDABs. And then in terms of the selection criteria, the broadest consensus was for drugs with the highest annual expenditures, with broader consensus for drugs that patients identified with real-world experience, drugs for chronic conditions, drugs with high out-of-pocket costs, and drugs with high prices. And I would point out again, less interest in ranking drugs that met special designations like orphan drug criteria, gene therapies, drugs that require special administration, or emergency drugs, or drugs for acute events. So that's my summary. I would say you're looking at getting public input. It wouldn't be that hard to post something similar to this on your website to collect some of that, with maybe just thinking about it blows up a bit quicker when you add, a lot of comments to it in terms of the amount of work that goes into that. But it might be a nice way to, collect some of this input as well as allow, for people to include some of their own perspectives.
Yeah, that's a good idea. Okay.
Yeah, that's very helpful and probably a good idea. Yeah, I mean, I think, it might blow up with the individual comments. But the charts would flow pretty nicely. So, any questions of Joel and the PDAC's work?
Super helpful.
Thank you. All right. Then with that, we will move to item number 8, the Executive Director's report.
Thank you, Mr. Chair. Actually, what Joel's comment just is a nice segue into the first part of the report here in terms of patient and stakeholder engagement efforts that the PDAB has on the books and anticipates getting on the books in the near future. We have secured the ability to participate at an exhibit at FarmFest. We'll be sharing the table with another part of the Department of Commerce, but there's the possibility of at least one, if not two, representatives from PDAB being at that at that event. That event is in Redwood County, which is about 2 hours southwest of the Twin Cities, not quite 2 hours, and very close to Redwood Falls, the city. I didn't know this before, but it does actually take place in a farm field. Yep. With tents and other things, but it's an incredibly well-attended event and a popular event. I plan to probably be there, go down that morning of the 4th, which is a Tuesday, and then leave the evening of Thursday the 6th. I'll stay in Redwood Falls for a couple nights, but would like to solicit volunteers from the board if anyone is interested in coming to help at that exhibit and talk with patients. I am working with Commerce Minute to really establish the connection with our website, a QR code, where we can, at that event, have literature with a QR code on it where we can direct people to a place on the web page where they can provide that information. Joel, we could provide your survey there that they could fill out, or a shorter form that is just what we've done at other listening sections, which is what are your affordability challenges that you're facing with prescription drugs? Are there specific drugs that you're having difficulty affording? And so I think either way, we're collecting data that's going to be important and inform decisions that we're going to be making over the next several months about patient-identified drugs that should be on our list for review. And then also, what are the important criteria that we should be looking at as we do these reviews? So I view this as an opportunity to hopefully gather quite a bit of information. We may end up with a lot of information to try to compile and analyze, but we'll see. That's a good problem to have. I've also been talking with Take Action Minnesota. It's a patient advocacy group that has larger goal of promoting healthcare access throughout the state, but they've taken a particular interest in the work of the PDAB, and they have offered to help drive. They're not sponsoring the event. This will be a PDAB event, but they've offered to help drive participation at an in-person evening event. I'm taking into account a lot of comments we've gotten from public that even people really, to get good participation, daytime events just don't work well for a lot of people. It's hard for them to fit that into their lives. So this would be an in-person evening event the week of October 5th. I chose that week and have suggested moving our October board meeting back because I want to solicit the same type of input from people at that so that we can have that input, compile it, and have it in front of us when we look in October at choosing drugs for selection. So I'll send out a survey of board members, actually for both Farm Fest and for this event, if they're interested in participating, and what would their availability be in terms of dates. I'm guessing that October event is probably a Tuesday, Wednesday, Thursday type event. And then I am also talking with a national patient advocacy group about helping to drive participation in a virtual evening event, probably again in that October timeframe, although this year is a little unique because people's attention to these things are going to start to shift to the elections as we get closer to November and getting participation. So I'm still deciding whether it makes sense to try to squeeze that in before the election or get past the election and then do an event in a later November, early December timeframe before the holidays hit. And I don't stop and see if board members have any opinion on that.
I actually do. I mean, I think at a time when people are politically aware, PDAB very well may be a topic of conversation around the state in the political environment, and it might actually drive attendance in a way that's helpful. And also, after the election, we will have already set, according to our schedule, we will have already, sent our drugs out for cost review, and the public input wouldn't be as valuable in this first round. Once we've already made those decisions, then once the cost review is done, it's a determination from the cost review as to whether there's affordability challenges. So I would advocate for the earlier time.
Yeah, so based on that comment, then trying to fit that in, maybe that week of October, additional event the week of October 5th, no later than the week after that, to still have time to compile information and bring it to a board meeting. And then the other item to report on these activities is I have had a preliminary discussion based on conversations and advice from the leadership team with a consultant who, kind of a public affairs consultant, who's done a lot of work with the employer community on healthcare issues and putting together town halls and getting engagement and doing media, other events like that to help drive participation. There's been a discussion at the leadership team. We've looked at a budget, which I assume in the next month or two we'll actually bring to a board meeting to look at. But there is money available, certainly in this next year, to engage a consultant to help us with that. And I kind of view it as, let's see how it works. Let's see if it's worth the investment or not to do this. Let's give them a chance to see if they could put together at least 2 or 3 events where we really drive good patient engagement. Let's see if I can get down here. Yeah.
Sorry, so just to kind of clarify in the consultant, so, and you referenced the budget, so is that something that we will discuss as a board then, kind of go through the options? And because I'm wondering how this kind of coincides with the conversation around staffing versus a consultant.
Right. And I think I did share a draft budget that accommodates staffing and this position.
Great.
But so that was something I think I shared with the leadership team a couple of meetings ago. We'll come back to that and we'll agree on something we could put in front of the board.
Great, thanks.
So we have our annual meeting that we designated earlier in this meeting, and I'd like to ask James to kind of provide an update on what the board election process will look like at the annual meeting.
All right, is that on? Okay. I'll tick through some reminders. The election process will look virtually identical to what you did last year. We just want to give everybody a refresher at this meeting to give you time to think about it, think of questions. I can either take questions now or before the next meeting. So the bylaws provide for election of 2 officers, a chair and vice chair from among your members. No member shall hold more than 1 office at a time. No member is eligible to serve more than 2 consecutive terms in the same office. So that does mean this time around that both Chair Lori and Vice Chair Nick Pay are completing their 2nd terms. So they would both be ineligible for their respective offices at this election. The election takes place each year at the annual meeting, and it's by majority vote. Nominations from the floor will be permitted prior to voting, and the elections for each office will happen separately. So the nomination process for each office will take place separately. Nominations do not require a second, and nominations can be made either for others or for yourself. The purpose of nominations is to endorse another member or to express interest yourself in being elected to an office. But when the vote is taken, members are allowed to vote for any eligible member, so you're not limited to nominees. Terms of office are for 1 year or until the successor is elected. The term of office begins upon conclusion of the meeting at which the election happens and ends upon conclusion of the meeting at which their successor is elected. Elections take place by ballot, which will be distributed to you before the vote. And so for any members who anticipate, or even if you don't anticipate it, but if you end up appearing at the July 31st meeting remotely, please make arrangements with our executive director for the voting procedure, and we will allow votes by members who are appearing remotely. And I think I already said this, but this is next in my bullets. Separate elections held for both offices. Chair will be elected first, so you will know the results of the election for chair when we make nominations and then do the election for vice chair. And I was improvising a little in the middle, so I think I've covered the rest of my bullets.
Are candidates able to coordinate with their super PAC? Or is that
The Supreme Court hasn't ruled on that yet.
No spending limit.
I'm not aware of any.
James, can I ask 2 questions?
Yep, go ahead.
First, can you remind me, is the 3rd member of the executive team a nominated position?
No, and this is a change from when we created our first version of bylaws versus, I believe it was a little over a year ago when the bylaws were amended. So the executive team, the leadership group, the various names that are sometimes used, that's an informal group of less than a quorum of the board that is used to kind of move business forward between meetings. But that process and how that works is up to the chair and the vice chair, I guess I should say, because those are the only elected and official members of the body.
Great. And then my second question, some of the board members are coming up on the end of their initial appointed term. Does that matter in this process of nominating and electing officers?
No, that's a good question. I believe, I've looked at this recently, but I don't have this information in front of me. I believe we have 3 members whose terms are currently set to expire in January of 2027. And so there would be no provision in the bylaws or elsewhere saying anything about that. So it's appropriate for somebody to be elected as an officer in July of 2026. If for some reason their term ended and they were not reappointed, we would have to look at the bylaws for if that would be a position that would be replaced kind of out of the normal cycle that we're on, or if that would be done at the next annual meeting. I don't know that answer off the top of my head. But it does not in any way disqualify them from the process that we're about to go through.
And
I think that's
a point
helpful.
of
Just one quick, I'm sorry.
point of fact too, two members, Erica and I both had our terms expire at the end of last year, and we both now have been appointed for a full 4-year term as well, if that was a part of your question.
That was, thank you.
Well, and if it would be helpful, I can provide the board with the roster and when seats are up for reappointment, if that just helps kind of frame things for people. Okay, I'll continue on here. I just have a little further to go. We don't need to do it today, but at the July 31st meeting, we need to determine our board meeting schedule for September, October, November, December, ideally. We had been in a regular pattern of setting the second Tuesday of each month for these meetings. I think I've suggested, at least for September and October, that we move those meetings to later in the month to provide us a little more runway to get our work done. But I'll send a survey out in advance of that July 31st meeting to see what options work for people. I think some of the professors on the board have their teaching schedules now. So that was part of the reason we haven't set these yet, but I think that's available now, so we can move forward and do that. And then just real quick, just a run through of the upcoming calendar. We've talked about a lot of this. The annual meeting is our next meeting. We've got Farm Fest. We do have an August 10th board. It's not an official board meeting, it's a work session. But it looks like we would have a quorum there so that we can do work and we can take votes. But the idea would be to finish our work on the governance quadrants there. Next week, I'll send out where those quadrants stand right now in terms of draft and solicit one more round of comments from folks. And then I believe we've got Erica, Matt, and I, and Stacy Shulgren, a meeting set up that last week in July to go through those comments and finish our work on the quadrants before we go to the August.
And just so that everybody knows, that's still a public
Yes.
meeting, and it will be posted, and the public is
Yep.
willing to come. So it's in compliance with the open meeting law. It will be August 10th, but it isn't a full board meeting. It is restricted to governance. So if you really care about that, you're more than welcome to come, and we will publish the time and place and location.
Yep. Yeah, and it is scheduled for August 10th here at the Wilder Center. Unfortunately, we won't be able to use this room. We'll use one of the smaller ones, but I will say that the intent is to use this room on a go-forward basis for the meeting, because I think we witnessed today that things work a lot better here. And that's all I have to report today, Mr. Chair.
Excellent. Any questions, comments for the executive director? All right. Well, then we will move on to our 9th and final agenda item, the public comments. At all meetings, we take comments from the public, and we are happy to hear from anyone who wishes to address the board about our work and this subject area. We ask speakers to identify themselves and any organization they represent. As noted at the beginning, please do know that these will be recorded and will be public. And we ask all speakers to kindly limit your comments to 2 minutes so that others have an opportunity to speak if they wish. We also remind you that written comments are always accepted and will be forwarded to the whole board, and we do see them and value them. And as I mentioned earlier, if you wish the comments you submit in written form to be public, we will make them public if you indicate you want them to be. And please also understand that the PDAB generally takes action by formal deliberation and voting as a board at public meetings, so it's difficult for us to respond real time to pointed questions and comments that come in the public comment section. Board members may ask clarifying questions, but please don't take a lack of response as a lack of interest. We really do take our work seriously and value the input of people who take the time and energy to engage with us. So with that, let me ask people online to please raise your hand to be recognized, and I will start by asking anyone in the room here, while people raise their hand, if they have any public comments they wish to offer. Anyone in the room? I see none in the room. Anyone online? Any hands online? Going once? Oh, okay. You have another minute to raise your hand if you think of something last minute, because I guess Vern, we needed to say one more thing.
I apologize. There was an item I forgot to bring up in the data project, and that is the issue of board members getting access to the Commerce email system and to the PDAB SharePoint website. I've been talking with our business analyst and project manager who's helping PDAB through Minute. And the truth is, I believe the reason we just are not able to get board members access is everyone is using their own personal equipment, which is set up differently with different firewalls or different restrictions for access to things. And so we had a few weeks ago or a few meetings ago, we talked about having a designated Minute person help assist us to get individually lined up. I'm not sure how many board members have availed themselves to that, but I know, Saya, you have.
I'm like pretty far down the road.
Okay. So Saya had brought up an idea of, say, at the July 31st board meeting, that we go for an extra half hour. We bring in Eric from Minute, either virtually or in person, and we sit down with our own individual equipment, and Eric walks through how to get set up. I'm going to pose another option, which James and I have talked quite a bit about this, which I think I prefer, but it's up to the board. When we originally talked about this, we talked about the board members being issued their own PC and phone from Commerce. An advantage of that is it's much easier to get these things set up. It goes much more smoothly. Another advantage, especially as we begin doing our substantive work, is that all your PDAB communications would be in that one place and not part of either your work email or your personal email. And if we did face a situation where we had data requests, public data requests, or subpoenas for information, it makes that project much more streamlined. It doesn't expose the board members' either work email or their personal email to that kind of inspection. I think the downside that the board members considered at that point is that's another piece of equipment I need to be responsible for and keep track of. But I'd at least like to pose the idea that I think it has to still be voluntary for the board members, but I think I'd highly encourage the board members to avail themselves to getting a Commerce PC and a phone. It's not significantly expensive. Minute's getting an estimate for me, but I looked at this several months ago and it looked like it was maybe $1,000 a year, which is, we can accommodate in the PDAB budget. So I don't know if I'm asking for a motion or if people want to communicate with me individually what their preference would be.
I'll just comment, as people are considering that, I did contact Eric. He had been working with SIA, told me that the issue is not a VPN issue, which is his area of specialty, and so told me to call the customer service line. But I'm not convinced that having him, it might be another Minute person.
Right.
But having him here to work us through that, I don't think is going to be
Okay.
a great use of his time.
I'm also stuck in between.
And Matt?
And Vernon, I was initially opposed to a whole nother computer, but you have convinced me, so I, for one, am happy to go that route. I don't know what we need to do officially and how you want to handle that, but I, for one, would avail of that.
No, I don't think we need. Okay.
I didn't think so.
Okay.
We're advised, we don't need a motion. If you want a computer, talk to Vernon. He has yet to convince me, I guess. I'm on and I'm working and certainly not another phone. I did that for a while.
Understood.
But if you're having troubles, we want you fully engaged and there's this option available.
The only other comment I would make is as we do start putting, say, that master list, a populated master list in front of board members being able to access that on the SharePoint site, I think would be, and actually even more importantly, if that master list has non-public proprietary information data on it, we're in a much better place if that's taking place in that environment.
Well, I mean, I think we're going to have to impose that restriction. I don't think we would be wise to allow members to pull that onto a private device. I think that would make us a target and subject us to unacceptable risk. That would be my take. But even on a private device, you should be able to access the SharePoint site and work with the data on the SharePoint site from a private device. That would be my guess, but we will get further behind the technology aspects of that. If I'm wrong on that, that's what I had in my mind that would help you convince me I needed to a commerce-issued computer.
Can I just ask, what would be the estimated time if the idea is we're all going to get laptops from Commerce before, in order for I agree with the protection, but how long would that take to get those all issued per minute? It feels like kind of a heavy bureaucratic lift a little bit. As someone who works on that with my staff.
I can confirm, but I believe we went through that exercise when we brought Julie Olson on to help Commerce, and it was a matter of weeks and not months. For you, Erica, you're in kind of a unique position from the other board member because you are on a state system. Yeah, right. I'll confirm with Minute what the length of time would be. Having our own data analyst and our project manager helps move that along a lot more quickly. I realize you've had your own experience with this, but I'll confirm. I'll confirm that.
All right.
So I guess the ask would be to Matt Tobrin has expressed his interest. If others are interested, please let me know and I'll make the arrangements for that to happen.
Excellent. I still see no one has raised their hand. I would entertain one last motion.
Motion to adjourn?
That's the one. And the executive director will take the roll.
Craig Acomb?
Aye.
Aye. Matt Anderson?
Aye.
Aye. Erica Barnes?
Aye.
Aye. Tony Laurie?
Aye.
Aye. Saya Nickpay?
Aye.
Aye. Stephen Schendelmeyer? Aye. And Matt Tobin? Aye. We have 7 ayes, no nays. The motion to adjourn has passed.
And we are adjourned. Thank you, everyone.